Hello friends, hope you're all okay. You're all enjoying your life. You're also enjoying watching my videos. Welcome back to ultrasound teaching videos with Dr. Arshad Nadeem Awan. This time I would rather use the word radiology videos because now I have started uploading radiology sections as well. Radiology, ultrasound, radiology, x-rays, CT scans, differential diagnosis, all this will be included in my these videos. Today I'm going to start one of the topic, that is urogenital topic, or in other words kidney, ureter and bladder. Before going to jump on the pathological processes, I would suggest that we better look for the anatomical structure, radiologically anatomy, how it will appear on the ultrasound, how many parts of the kidney, ureter and bladders are, how it will appear on the ultrasound imaging, so that we should get the idea of the normal presentations of the renal system. So once we understand the normal renal system, we will be able to easily pick the pathological processes. So the pathological processes would be having in a separate video. This is particularly urinary system, including kidney, ureter and bladder, how it will appear on the ultrasound imaging, how we will appreciate all these components, and what are the normal parameters, including that. I will also discuss about the normal variants of the kidneys and ureter and bladder. So this will all be included in this lecture. So let's start looking for the normal structure which we can appreciate on the ultrasound imaging related to kidney, ureter and bladder.
On these images, you can appreciate the anatomy of the renal system. Towards the right side, you can appreciate a very beautifully diagram indicating renal artery and veins. Beside this, all the internal organs like column of Burton. So on the images, you can see the column of Burton, while on the ultrasound imaging, the column of Burton appears to be hypoequic. So this is what column of Burton, sometimes it may get enlarged and mimic as a tumor. You must be very careful. So that is the first point you have to be look after for the column of Burton, which will appear as an hypoequic. The second comes to the renal cortex. As you know, mainly there are two parts. The one is medulla and the second one is cortex. So cortex is mainly made up of parenchymal tissues, so it also appear as an hypoequic. So far medulla is concerned, in the medulla there are multiple structures, and there are especially sinus fats. So because of these fatty structures, it appears hyperequic. So the main difference between the medulla and the cortex is cortex appears to be hypoequic and medulla appears to be echogenic. So this both differentiation is very important. You have to differentiate between the cortex and medulla. This is called as corticomedullary differentiation. If it is intact, it means the liver is the kidney is normal, and if it is lost, so it means that it shows renal parenchymal disease. In renal parenchymal disease, corticomedullary differentiation would be lost, and there will be no longer possibility to visualize clearly the margins of the cortex and the margins of the medulla. So must be very careful. By the time you are scanning the patient, start straight away look for the cortex echogenicity and the medullary echogenicity and the differentiation between that. The third comes the point of pyramids. Pyramids appears to be a hypoequic. You can appreciate these small hypoequic areas which is projecting within the cortical part. The take home point is sometimes this pyramids gets slightly distended because of the fluid filling, so that might be mislabeled as a pelvic calyceal dilatation, which is not a true case. So therefore you must be careful to look for the pyramids. Sometimes they will be prominent pyramids which may be congenital or maybe because of overfilling of the bladder. So you should not misdiagnose it as a pelvic calyceal dilatation, or sometimes some of the new clinician may refer it to as a simple cyst. So these are not the simple cysts. Next comes fatty sinus, which I have already indicated, because there are multiple fats within the medullary region which appears to be hyperechoic, and it will appear as an echogenic. Next, there is a part which is called as renal pelvis. Renal pelvis is a very important area which needed to be carefully looked for. Sometimes there is a pelvic dilatation. This may be congenital or this may be pathological. So you have to be careful whether this pelvic dilatation or baggy pelvis or baggy renal pelvis is congenital or there is some pathological process is sitting. Ureter is normally not visualized until unless it is dilated or it is enlarged because of the intraluminal mass or intraluminal stone stocking. So otherwise you cannot appreciate ureter, a normal ureter on the ultrasound imaging. The next very important take home point is a renal artery and vein. You must assess on the Doppler imaging, put the Doppler signal on and look for the patency of the renal artery and vein. It is very important, especially in those who have developed newly hypertension and there is suspicion of the renal artery stenosis or renal artery thrombosis. For the better understanding, again, you can appreciate the right side image. On the left side there are two ultrasound images. So look for the first important thing, that is a renal capsule. Capsule is very important. Sometime in a benign condition there may be exophytic cyst which may be projecting from the capsular region, so that would be considered as an exophytic simple cyst. But in case of tumor, you must be very careful for the capsular breaching. Sometime in renal carcinoma there may be a breaching of the renal capsule which will put into the second degree or third degree, so therefore you must be very careful to look for the renal capsule. Cortex has been already discussed. Medullary pyramid, we can also we have already discussed this renal pyramids. Renal sinus fats can be seen on this image very clearly. Renal pelvis can be easily seen and can easily be distinguished. A column of Burton, which I have explained in the previous slide, that you need to pay attention. In some beings there will be enlarged column of Burtons which can be confused with the presence of mass, so be careful that is it truly column of Burton or it is renal mass. So this is one home take point for you guys. Ureter, as I mentioned, that you cannot normally appreciate the ureter on the ultrasound imaging unless it is enlarged or it is distended. Doppler ultrasound is a criteria to assess the renal artery and veins. Sometime in newly developed hypertension or in persistent hypertension there is likely chance of renal artery stenosis. There will be hypotension to the renal parenchyma, resulting into increased secretion of the renin and causing the hypertension. So it can be easily assessed on the Doppler imaging, provided that the clinician should be expert in the Doppler imaging. This image particularly explains the collecting system, including renal calyces and renal pelvis. Here you can appreciate that renal pelvis is dilated, associated with small calyces. Calyces are also dilated. So there are simple calyx, there are multiple calyces. So you can appreciate from right to the left all the way around. So these are all calyces. So the term we are applying for pelvic-calyceal dilatation, this pictures truly shows the pelvic-calyceal dilatation. Must keep in mind that sometimes this may be because of overfilling of the bladder, and maybe rather you would say it physiological. But if there is a true pathological processes, ask the patient to go and empty the bladder, and then after that 5 or to 10 minutes break, just rescan, and if it still persists, it means that this is the pathological processes. One another thing worth mentioning here, that in some there is a criteria for mentioning the mild, moderate and severe hydronephrosis. For that purpose you have to look for the thickness of the cortex, so which I'm going to explain it to, into the next slides. So here this was only to explain that how pelvic calyceal dilatations will appears, and you have to be very careful whether there is any stone or any other sloughed papilla stuck into the distal calyces causing pelvic calyceal dilatation. Again, it's a sort of revisions for you guys. Look for the renal pelvis, and here renal cortex is clearly visible. Renal capsule is already marked. Renal pyramids or medullary pyramids can be seen. Renal sinus is echogenic because of the fat presence. You can see minor calyces. You can also see major calyces. Sometime there may likely be a major or minor calyx dilatation. In that case, the word that we are using and the terminology we are using is calycosis. So you can use also that word if you are pretty much sure that either one or two or a focal or in upper or middle or lower focal calyx or calyces are dilated. So you may apply that word as a calycosis if any particular calyx is enlarged. Look for this slide. Here you can appreciate the measurement. So for the length is concerned, you have take the length in the way you can appreciate in this image, and it shows 10 to 12 centimeter. And also look for the width, which is 4 to 6 centimeter. There are multiple criteria, there are multiple researchers, but again I would say it also depends upon the body habitus, the body enlarged, the body size, the body growth. So for normal limit is it's a 12 centimeter. Greater than that cannot be considered as enlarged kidney, but the best is whosoever you are scanning, compare the both kidneys, and if there is enlargement more than 2 centimeter between them, you can label that as an enlarged kidney. So this is what here you can appreciate, and you can take the measure in the longitudinal and in the width wise. So always measure both kidneys and mention on your report both the length and the width. Here you will see sonographic criteria for the hypertrophied column of Burton, which I'm going to show you the pictures in next slides. So what it is, it's indentation of the renal sinus laterally bordered by junctional parenchymal defect, and it will continues with the adjacent renal cortex. Mind you that the column of Burton will be in continuation with the renal cortex. There will be no discontinuity, which is making it different from the renal mass. A similar color flow to the surrounding parenchyma. If you put the Doppler signal, so it will show both in the column of Burton and the parenchyma as well, and it will also contain renal pyramids, and this would be less than 3 centimeter in size. It should have been less than 3 centimeter in size. Here this image shows clearly column of Burton parting the medullary cavity into two, but it is with the continuations of the external lateral renal cortex. If you look carefully, you can see that there is some partition in between two, and if sometime it may rise to suspicion of a tumor, which you should be very careful for diagnosing that, and you should not misdiagnose as a hypertrophied column of Burton with the tumor. So this is a clear picture showing you that this is an example of the hypertrophied column of Burton, which will appear on the ultrasound imaging in this fashion, and it should not be more than 3 centimeter. Here this is a transverse section, and on the transverse image you can appreciate that it will mimic like that, and here you can clearly see that the column of Burton is in continuation with the renal cortex, and this will explains you that this is not the tumor, this is the real column of Burton. This is the one thing where most of the clinicians misdiagnose the tumor, and they mislabel the column of Burton with the tumor. The main important thing, another view is like here, this is another picture just for the clarification and to take you these home points, and also to clarify your mind that whenever you come across column of Burton, you should not confuse and you should not mislabel that case. After confirming this column of Burton and taking the size, the another criteria that we do have is Doppler imaging. On the Doppler imaging, which will help you again to recognize true column of Burton, and you have to apply the Doppler image on that. An example of the Doppler scanning, here you can appreciate that it shows vascularity as it should be on the cortex. So this vascularity, there will be no difference of the vascularity between the column of Burton and the surrounding cortical region, which will explain you that this is actually the part of the cortex which is indented within the medullary cavity and giving a particular shape. This is column of Burton. On this image, particularly the dilated ureter can be seen, and here with the red it is mentioned that it's a kidney filled with the urine, which is not the proper word to be used as a urine because this is infiltrate, so we cannot use that word here until it is confirmed. But anyway, you can see that the pelvic calyceal dilatation is will look like this, and beside this the ureter is also dilated. So again, I would mention here it would may be physiological. To confirm the true pathological dilated ureter, you have to ask the patient to empty the bladder, and after 10 minutes just rescan, and if it persists it would be pathological, otherwise it would be just reflex. This is another ultrasound image which is explaining mild degree hydronephrosis with dilated ureter. The patient had been asked to empty the bladder, and after 10 minutes this scan was taken and it was still persist. Beside this, with a thorough examination and thorough research, it was found that small tiny stone was stuck in the distal ureter, causing this proximal dilatation. So you can appreciate that there is dilated ureter which is very clearly visible, and that's the proximal part is of the ureter is dilated. Beside this associated with mild degree pelvic calyceal dilatation, or even you can frankly label it as a mild hydronephrosis. So these dilated ureter and mild degree hydronephrosis will look on the ultrasound imaging like that. Must look for blockage in the distal ureter. For the urinary bladder scan, it is important that the bladder should be filled, sufficiently filled. How much filled? It depends upon the individual to individual. It depends upon the patient's capacity, and it also depends upon the patient holding the bladder. So, but you need to have a full bladder if you want to assess intraluminally, because sometimes some small polyps, polypoidal lesions, transitional cell carcinoma may be sitting in the base or on the lateral walls or on the superior wall. You have to be very careful for the scanning of the bladder. So here this is the bladder in the male, and down you can see two small seminal vesicles, and there will also be prostate. So you have to be very careful for the prostate and bladder defects. So here on this image you can appreciate the bladder is clearly visible, and down to the bladder and beneath the seminal vesicle you can appreciate the prostate. So this is the prostate and how it will look like. You can appreciate that the normal prostate size is 30 grams. Less than 30 gram it should be, and if it is more than 30 it will be considered as an enlarged prostate. How you will take the prostate measurement? There is a criteria, there is a proper procedure. You have to follow that criteria, and also ellipsoid formula to take the volumes. This image just to show you that the normally prostate will look like that, and you will have to look for the bladder in view as well, and also the bladder wall thickening. This is how the bladder will look in the ladies, in the female. Here down to the bladder you can see the uterus and also surrounding rectum and bowel gases, as well as a urinary bladder, full urinary bladder gives a good and great window to visualize the pelvic structure. So at the same time, when the bladder is filled, you can also appreciate all the pelvic organs very clearly in the female. Even the ovaries can also be picked up on the full bladder scan. The main important thing is you have to measure the volume of the bladder as well, to look for the pre-void volume and the post-void volume. So again, you have to apply the ellipsoid formula for that matter, and you should be very careful to observe the internal and external, the lateral, medial or superior wall. So far the urinary bladder views are concerned for taking the pre and post void volume. This is what the way is. You have to utilize the ellipsoid formula in these dimension. You have to take in transverse and take the two measurement, and then take the longitudinal view in the another window, and in the longitudinal view take the measurement. So these three measurement, which is actually the ellipsoid formula, it would be automatically adjusted on your machine, and it will give you the volume. So that would be the pre-void volume, and you can also assess the post-voidal volume on at this on the same procedure, on the same view.